All right, good afternoon, everybody. Thank you again for joining us for this month's edition of Grand Rounds. We have Dr. Perez, one of the newest additions to our neurosurgery team at Insights, and he will be presenting on, and forgive me if I screw this up, but trigeminal neuralgia, percutaneous approaches, and surgical outcomes. All right, take it away, Dr. Perez.
Thank you, Siraj. Good afternoon, everyone. It is always a pleasure to speak on trigeminal neuralgia. I personally, as neurosurgeon, we face different painful conditions, but just treating patients with this situation is just a little bit more than this. I have had the opportunity to treat patients in the last 19 years, and trigeminal neuralgia patients are the ones that actually I've been committed to provide the best we can with these individuals. Before they get to you, before they get to the office, they actually take some time to go to the doctor. They can take between 10, 15 years to really seek medical attention. So when they come to your office, they're actually desperate to have some medical or surgical treatments. And the reason I choose this presentation, first of all, because I was invited to speak on trigeminal neuralgia, and second of all, because I see this as a tremendous opportunity to really start our practice. Actions speak louder than words, and having the privilege to work in Insight and just be there and see this center with tremendous amount of potential to work in so many painful conditions, and trigeminal neuralgia is definitely was a great opportunity. I will spend few seconds just describing about the anatomy of the region and also the clinical description, and at the end we'll touch upon the surgical nuances. Just as introduction, trigeminal neuralgia, it has an incidence of 4.3 per 100,000 population. It is a little bit more common in women than in men, and there is a wide variability between countries. If we check some of the world statistics, this is a little bit difficult to understand why in some countries it's got such a high incidence, and some other countries, I believe it is underreported. Multiple treatments have been reported for these conditions, and the list of medications is just growing every single day. We have anticonvulsants, antipsychotics, antidepressants. Any variety of medication is being used for trigeminal neuralgia. And the kind of treatments, it is actually very interesting to read. You can see, the list of this, I would just call it techniques. It's not exactly procedures or medications. People were doing head banging. They were using chinchona in South America. They were using cannabis in the past. They were using different either medications, drugs, in order to get rid of the pain. So at the end, multiple radiological studies might be non-relevant. For these patients, we select CT of the brain and also MRI of the brain. And at some point, even if we carefully analyze the anatomical details, sometimes all these studies are non-relevant. They don't show so much of abnormality. And again, multiple surgical procedures have been described. With this slide, I'm showing to you what is happening with all the procedures that have been done over the last 10, 13 years in trigeminal neuralgia. As you can see in the slide, and I'm trying to point it out, starting in 1992, and I don't know why, most of the procedures split it in this curve. You can see that the upper part of the curve, most of the procedures done here in the States basically were considering microvascular decompression. And the lower part of the slide was showing us that for some reason there was a lot of interest, or there were not many procedures being done with percutaneous approaches. And this is something that has got my attention, and I went ahead and I checked up a couple of the slides. In this one, for example, if you compare microvascular decompression, rhizotomy, and stereotactic radiosurgery, most of the general characteristics basically are about the same: age, length of stay. But then something is showing up here very interesting. Primary payer, I don't know why, the private insurance companies are paying for the microvascular decompression, and basically institutions such as Medicaid, Medicaid are paying for the percutaneous approaches. Why is that difference? Well, it's something we can discuss at the end. Median household income is also different. As you can see, the average amount of income And this individuals is different than these ones. And again, it's a pretty interesting socioeconomical parameter to consider. Again, some of the complications that we can encounter in this procedure, and this is just comparing one procedure to the other. In general, microvascular decompression has many more complications comparing to all these percutaneous techniques. And and also the impact of these complications might be something that is not pretty well described in the papers. In general, any patient developing a major complication with microvascular decompression might have the terrible burden to really go into a lot of different costs and different treatments in order to have some improvement. Now, let's consider some of the anatomy. Trigeminal nerve, it is the widest of all the cranial nerves. If you check the anatomy, the trigeminal nerve is always at the center. You see this typical picture, and the one I'm showing is the trigeminal nerve. So you see these three branches, the ophthalmic, the maxillary branch, and the mandibular branch. And then, we have many peripheral branches, very small branches. In general, it has a very extensive anatomical variability. The trigeminal nerve is taking basically innervation of all the face, the scalp, the mucosal surface of the nasal cavity, the oral cavity, the two-thirds of the tongue, and this is basically conveyed by the facial nerve, but it's coming to the trigeminal nucleus. And also in this typical slides, it's just very simple to show that these three divisions, these three main branches, they converge to the gasserian ganglion, and from here goes to the pons, and then from here it goes to the different regions, which is basically mesencephalon here at the top, and then medulla oblongata at the bottom. So simple as it is, there are so many branches to describe in this presentation. I'm just gonna go in pretty quick details. We can see this the supraorbital and supratrochlear nerve. They actually make up the frontal nerve. Also we have the lacrimal nerve, and the maxillary branches. We can see different nerves extending to the maxillary areas and also to the frontal sinuses. All these tiny branches, again, they go to the main nucleus, which is located here at the pons. So why all these percutaneous approaches have been developed in the past? Because we know for sure all these sensations, they go to this place. And before reaching this place, we have a tremendous opportunity to really localize this nerve, which is pretty thick. And we can block it, we can ablate it using all these techniques. So what is causing the trigeminal neuralgia is a question that we all of us ask us all the time. Well, there is a theory that has been there for years, and I'm not pretty sure about it, but this is the one that we've been basically dealing with all the time. For a lot of specialists and a lot of pain doctors, the trigeminal neuralgia is caused by vascular compression. So the bottom line is very simple to understand. You hit the trigeminal nerve somewhere, and you have these vascular branches basically hitting the nerve with any pulsating bout, and it's causing the nerve to trigger the zone, and then this is when the patient feels every shooting pain. So it is very simple to understand. Any vascular compression is causing the nerve to really trigger. But we also see some asymptomatic patients with arterial compression. This is actually makes no sense. Sometimes the clinical syndromes are so complicated that it's just difficult to really put this theory as a causative agent in this case. We also see a lot of arterial compression, but we also see venous extractors sometimes compressing the nerve. And then the trigeminal nerve is getting a lot of attention for a lot of neuromodulation techniques, because as we know, the trigeminal nerve is got some what we call suprasegmental centers. And these are basically areas a little bit high in this representation, and they basically modulate the pain responses. So we see the periventricular great substance, we see the nucleus or raphe magnus, and all these centers, they modulate basically all the incoming sensations coming to this specific nuclei with the trigeminal nerve. Now, how all this information basically represents some clinical opportunity, so how we can take this information as valuable. I would say one of it is just being able to really correlate all this, basically all these centers with what is happening with patients' clinical response. So this is a very interesting paper describing all these areas using DTI, diffusion tensor imaging. Some years back, we didn't have any opportunity to really look into these areas, Now we're able to see what is happening. And in this very interesting paper, these researchers were able to show up which are the areas that actually related to the trigeminal nerve. But not only trigeminal nerve, but also the pre-op and post-op conditions, which are basically depicted here at the column, and also comparing this information with the healthy subjects. So now, according to the researchers, whether or not the patients utilize the centers is something that we can't actually answer at this point. What we know for sure is the patients have the ability to really communicate these centers and how every patient is showing different response. And this is something that we were discussing for years. How in the lab, some patients get like immediate response, and some of the patients get no response at all, even though the procedure is about the same. Well, the answer is this, because we have suprasegmental centers, and that is why every patient is different, and every surgical procedure is going to show a different response. Now, what is the clinical description of trigeminal neuralgia? Any pain in the face is not trigeminal neuralgia. We have to be very careful on selecting these individuals. And this very simple presentation, I wanted to basically have some time to describe it. Trigeminal neuralgia is actually classified in two types, TN number one, TN number two. TN number one is a sharp shooting electrical shock-like pain, which is a pain that most of the time the patients referred as very intense, unbearable for some of the patients. Now, the trigeminal neuralgia type 2 is an aching, throbbing, burning. It is a little bit more constant than the TN number one, and I can just call it a typical trigeminal neuralgia. Now, we have a couple of examples with trigeminal neuropathic pain, and this is any pain that arises any major trauma in the face, the skull base, and also may see as related to a stroke. And finally, we have the trigeminal deafferentation pain, which is a pain that we might cause utilizing this percutaneous procedure. We also have symptomatic trigeminal neuralgia that arises after multiple sclerosis, or the one that actually arises post herpes is called post-herpetic trigeminal neuralgia. And then there is a very interesting psychiatric situation that is called atypical facial pain. This is not pain, this is actually a psychiatric condition. And we need to be aware of this because I had a couple of patients that actually I have some difficult time trying to understand the patient's description, and at some point it turned out to be psychiatric in nature. Just making sure that you follow all these clinical guidelines in order to select the patients. Now, the history of trigeminal neuralgia, it is one of the most fascinating in neurosurgery. We used to tell between neurosurgeons that it hasn't been any single entity as trigeminal neuralgia in the sense that we have so many procedures, so many descriptions. We have brain procedures, we have peripheral percutaneous approaches, we have radiosurgery, we have every variety, including DBS, for trigeminal neuralgia. Why is this? We might not get the right treatment for every patient. And as I said before, every patient needs something different. Now, starting in 1950, Sheldon and Pudens, they started the percutaneous compression with trigeminal neuralgia. At the same time, Tan Harsh published the subtemporal decompression, which is one of the skull-based procedure. In 1960, Janetta rediscovered the exploration of the posterior fossa. And then the list goes on. In 1965, Sweet published the use of radiofrequency for surgical treatment of the trigeminal neuralgia, along with Mulan utilizing the Fogarty balloon. And then at the end, in 1971, radiosurgery was treated utilizing, trigeminal neuralgia was treated utilizing radiosurgery. Now, which are the procedures that we want to describe in these few minutes? Well, we have three procedures to describe. One is called percutaneous rhizotomy with glycerol, percutaneous balloon compression, and percutaneous thermocoagulation with radiofrequency. So the three procedures, they have something in common. And this is basically the technique that we use in order to localize the trigeminal nerve. So as you can see in this slide, this is a typical patient. This is just before the procedure. We localize 2.4 centimeters, 2.5 centimeters to the side of the labial commissure. And then we consider this coronal plane that is basically giving us the chance to intersect this line. And then we aim the needle to the foramen ovale in this direction. Now, in this drawing, which is one of my colleagues actually put it together, we can actually go to the specific entrance point, which is the foramen ovale. This simple hole is foramen ovale, and this is the area that I need to target with the needle. So basically, in other words, what I used to tell and what I used to teach the residents, You take this sort of like a pyramid, and then you aim the needle to the vertex of the pyramid to be able to target the foramen ovale. So this is basically the picture that we can get. You see a typical fluoroscopic image, such as this one. And now I'm showing what is called glycerol rhizotomy, which is same technique, Hartel's approach, but instead of using radiofrequency, we can use what is called tantalum or maybe anhydrous glycerol with a mixture. And then once we have this typical picture, we can use what is called cisternography, which is the placement of to the contrast media. And then once we see the typical image of the cisternogram, we can place the tantalum there, the glycerol. And at the end, we sit the patient, we let him rest for a few minutes, and then we just allow the patient to move after half hour to be able that the patient doesn't have any additional exposure to the tantalum. Now, the second technique is called percutaneous microcompression balloon. With this technique, is basically utilizing general anesthesia. We cannulate the foramen ovale with the same technique, with the same Hartel's approach, and we use a number four Fogarty balloon. As you can see, the needle is here, and then the balloon is placed inside of the cannula, and when it is in place, we inflate it, and we just let it rest for for 3 minutes, and then the patient can be wake up, and then we basically monitor the patient response. So these images I can show you typical general anesthesia, testing the balloon. Here I am trying to find the foramen ovale, and then once we find it, then we can place basically the balloon as this picture is showing up here, and then we just leave it inflated for 3 minutes to be able to really lesion the peripheral fibers. Now let's go with the trigeminal rhizotomy, which is, I would say, a little bit more difficult than the previous one. And with these techniques, basically is my own technique. There are many techniques that you can find in the papers, and you can utilize different projections with the fluoroscopic imaging. I personally, and having the chance to work in some hundreds of patients, I've chosen this technique as the simplest one that I can use. Basically, we position the patient same as any pituitary surgery. This is the way we position the patients before doing any pituitary approach. Then we localize the sella turcica, and then once we're able to see it very, very clearly, then we proceed with anesthetic monitoring. These patients are totally different than the other patients. These patients develop bradycardia as part of the normal response. And most of the anesthesiologists are actually aware of this because, we have a couple of cases with cardiac arrest. You need to be prepared for any emergency, and you need to provide the typical ACLS just in case if anything happens. Now, this is one of the videos that I really enjoy showing to you. This is the typical patient, and here I am trying to select this typical view. But before doing it, we have to play with the typical patient's head position, and then we can mobilize the head in order to see a clear picture. Once we are in a position, you see the needle coming through the medial portion of the orbit. And this is my favorite view. I would just call it transorbital view. And in this one, you see the temporal ridge showing up here at the center of the orbit, what I call the sunrise image. And then utilizing lateral imaging, then you place the needle here. Now, this shadow that we see here is actually the posterior tiny process, which is a tiny structure here. So this is very important in order to select the specific branch. As we have said at the beginning, there are 3 branches. So if the patient has got B2 and B3, which is the maxillary and mandibulary branches, then we target this area a little bit different. It's not exactly as this one, but you can see this is a clival line. This is basically for B2. B1 might be here, and B3 might be here. So then once we get to that point, we can see the CSF coming out. You gotta see this dripping there, because this is a pretty nice confirmation you are getting to the right spot. So it's not that simple to target this little foramen, but once you see it, it's just giving you the okay that we are in the right spot. So again, I'm just gonna show you a couple of examples. Again, placing the needle inside of the orbit. We're actually behind the orbit, not in the orbit, behind the orbit, and a little bit medial. And then again, as I just described, I like to see this image that I'm 100% sure that I'm in the right spot, that I'm targeting B2. And then once the electrode is placed, we proceed with the radiofrequency lesioning. Again, another example, you see the needle being placed, and then we replace it with the electrode. And again, you gotta see a typical CSF coming out dripping, and then once you are satisfied, we proceed with the lesioning. And then at some point, I guess it's extremely important to have the clinical correlation. Even though it's a procedure that might take us a few minutes, sometimes it's just a couple of minutes, sometimes it might be 10, 15 minutes, but it's extremely important to have the clinical correlation. So we used to have all these studies in OR, MRI, and basically to be able to understand what the patient's is the main complaint. If the patient is having B2, B3, then we see sometimes arterial branches crossing the trigeminal nerve. And then we actually can take this information as very important when we decide to do the rare frequency lesioning. Now, how is the postoperative outcomes reporting? Well, this is the most important part of our procedures to be able to have a feeling of how the patients are doing right after the procedure and maybe some months after the procedure. And now we also say that this might be difficult sometimes because most of the patients, when they come to you, they can travel long distances, they can wait some time for the appointment. Once they come to you, they're actually committed to provide clinical information to show you and to let you know how are they doing with the patient's response. So again, my own inclusion criteria, it might be a little bit different than others, but I would take any patient's age. Why is that? Because some patients are 17 years of age, or they might be. I did a lady with 95 years of age. They decide what they want in terms of a surgical procedure, and that is why I used to place this patient's preference. Why not? The patients decide whatever they want. And then something, the bottom line, we need to confirm the diagnosis in these patients. Most of the patients actually they failed medical treatment. They've been in medical treatment for years. They have a list of 10, 15 medications, and nothing seems to provide any additional benefit. Something important, we need to have no contraindications for the surgical procedures. Sometimes, especially age individuals, we need to withdraw the medications such as anticoagulants, antiplatelet therapy, 7 days prior to the surgical procedure. So, which were the hypotheses and objectives of this outcomes reporting? Well, the first of all, to afford favorable outcomes to the patient control, and this is something we talk to the patients. We know, and we can tell the patients, the trigeminal neuralgia is not a curable disease, and this is something that I can share with a lot of pain specialists. The trigeminal neuralgia is not curable with surgery at all. It's a long-term process, and we as a providers, as neurosurgeons, as patient specialists, we can improve this patient's pain intensity, but we are not curing the patient at all. The patient can have some recurrence at some point, and that is why it's extremely important to really express to the patients what all the outcomes are going to be. And once the patient understands what they want, then we might proceed with surgical procedure. We also need to consider lower hospital stay and reduce complication rate. Now, how can we describe all these situations having so many pain intensity scales? Well, this is something that we have a problem all the time because some of the patients are actually followed up by some colleagues, and they can just send you letters and say the patient is doing fine, has no pain at all, or the patient is having 50% pain reduction, which is a little bit easy to understand, but we need to use scales to be very precise when patients reporting outcomes. We also consider pre-op imaging in all cases. We need to rule out any brain tumor, multiple sclerosis, or something the patient might have before doing any surgical procedure. Most of the time, we do it in outpatient as an outpatient procedure. We used to ask the patient to commit themselves to give us a minimal or 1 year follow-up, so we know how the patients are doing, whether or not we can adjust medications. And then this is done with office visits, phone calls, some interview, etc. This is a typical scale we use in all of our patients. Simple descriptive distress scale. The patients describe whether or not they have annoying, uncomfortable pain. Maybe this can be done with numerical pain scale from 0 to 10, and also with a visual analog scale, no distress or available distress. Now, this is actually my own series. I've done more than 500 procedures. I've done probably 100 microvascular decompression and maybe between 40 and 50 microcompression procedures. But with radiofrequency, I've done 350 cases, and 290 cases, they actually correspond to a radiofrequency procedure. All the clinical charts were reviewed, and 280 cases completed the final follow-up. The mean age of these individuals was 59 years. Gender distribution, 110 females, 170 males. Diagnostic distribution, in these cases, most of the patients were trigeminal neuralgia, classical trigeminal neuralgia, with only 3% of multiple sclerosis, which again might be an indication to do these procedures, and 2% of cases with atypical trigeminal neuralgia. Now, not all the patients have all the branches affected. This is something we need to consider in order to select the right approach. As you can see in my slides, I have a little bit more than usual B1 patients affected with these conditions. And this is something that I've been talking to colleagues. Most of these outcomes are in the process to be reported. And one situation that I can describe to you in Mexico and in some other Latin American countries, and I'm sure it's the same situation, what is happening in Eastern Europe, we might see a lot of B1 patients affected with trigeminal neuralgia, and or this might be symptomatic trigeminal neuralgia, and this is because in our countries we have narrow cystic sarcosis, and this is just a personal observation. Whenever you go and you do the decompression, you see a lot of arachnoidal scarring tissue, and this is something that is related to the exposure of narrow cystic sarcosis, sometimes years before the procedure. And that is why, in general, you see a lot of B1 involvement in these patients compared to the States, compared to Europe, because the chances for developing neurocystic sarcosis in Mexico might be 10% of individuals. It might be between 7 and 8% in Eastern European countries, and this is something we need to consider in order to get the whole picture. Now, with all these patients, we had 90% of patients with more than 75% of pain reduction. This is basically considering the BAS scale. We saw 5% with moderate response, which is between 50 and 75% of improvement, and 5% with no response at all. These are the cases that I described at the beginning. This has to do with a lot of pain modulation mechanism. Now, we were able to show what is called clinical relevant pain improvement in the majority of our patients with P less than 0.05. Most of the patients, they were able to report immediate improvement. We also were able to reduce medications over the next months after the procedure. And then at the end, quality of life is just different with these procedures. We had some complications that I need to report to you. We have 5 cases with cheek hematoma. These patients were actually managed in a very conservative way. There was nothing to be done, except that we need to tell the patients how they can apply some local measures to get rid of the pain. We had transient paralysis of the 6th nerve in 10 cases. In these patients, they have double vision. You can see them, and then they have the typical medially deviated eye, and this is taking a little bit of a time, sometimes between 6 to 8 weeks. What we do with these patients, we just teach them how they can cover the eye, and they can actually control the double vision. We had a cardiac arrest in one case. We have also anesthesia dolorosa, which is a very difficult, painful condition to treat. We have also trigeminal neuropathy in 5 patients, and we didn't report any deaths related to the procedure. So what happened with the recurrence? Recurrence is actually how the patients report that the pain is coming back. They might take some time, between 6 or 8 months, and this is basically happening in 50% of the patients. And we need to tell the patients that the chances are a little bit difficult to understand, but it's not a simple factor. They can take, personal factors. They can take the surgical technique itself, but at the end, the patients can report recurrence in 50% of the patients. Now, at some point, we were able to use different parameters. The typical parameters we use in these patients is between 70 to 70 Celsius degrees exposure to the equipment. And sometimes, in some of the patients, these are redo procedures. We actually lowered the radiofrequency exposures. And then at the end, we had to provide some surgical treatment to these patients in 30% of the cases. Now, just utilizing all the scales, the single scale that I guess is the most important, the simplest to use is called the VAS, the Visual Analog Scale. The median VAS for all these patients at the beginning or right just before the procedure was 9.97, and then compared to the last follow-up was 111, which is basically statistically significant in these patients with a Wilcoxon scale. Now, how do we manage the post-op hypoesthesia? So with these procedures, basically 100% of the patients develop hypesthesia, which is a numbness in the face. So how do we do it? Well, I was able to really adopt some of the techniques that some of the colleagues were actually reporting. So there is a very interesting technique. It's called mirror therapy for phantom limb syndrome. So this technique was applied many years ago by Dr. Ramachandran, based in San Diego. So he was able to teach patients, and basically he reported in a couple of papers, how can you take a simple mirror, just place it in the sagittal plane, such in the figure of the bottom right, and basically you need to teach the patient how they can contemplate and they can concentrate basically in the healthy side. Once they're able to really concentrate for 20 minutes in the morning, 20 minutes in the afternoon, they can take this information and they can get what is called the visual illusion of healthiness. So at the end, they take this information, and I'll show you a couple of slides to explain what is happening in the brain. And then also in the trigeminal neuralgia, you see this lady that is basically using this typical frame. So what I was telling my patients, you can go to any, in our country, it's very simple to go to any small shop, and they can provide you just a couple of mirrors, and you just put them in right angle, and then they need to look themselves for 20 minutes. At the end, these techniques actually work. So as I said, this technique was described in 1996. So this is a simple technique. A mirror is placed, and the mirror reflects a healthy limb. In the case of trigeminal neuralgia, healthy side. And then this is a rationale using this technique. There are a couple of areas that actually show up in all the functional studies. One is located in the right superior temporal gyrus. The other one is in the right superior occipital gyrus. And the patients, they do improve over the months, over the weeks, right after the procedure. So in general, how all these techniques and all this pain intensity and post-op complications impact patients' quality of life. So they impact the patient's life. And we need to be aware how the patients need to continue in the follow-up. Some of the patients develop anxiety, some of the patients develop depression, and we need to be aware of all these situations to really refer the patients to the specific specialist. So I used to send the patients to my psychiatrist when I see that something is totally different, that is not basically pain, but these patients develop psychiatric situations. And all I can tell you, I've been witnessing so much stuff in this condition. And I had a couple of patients actually that they were scheduled to come to my clinic for surgical treatment. They were coming from Belize, and they committed suicide, basically because they didn't have resources to come to my clinic. And I was told, by the lady, actually, she wanted to refer to me these patients, and they committed suicide. So that's why the trigeminal neuralgia is called the suicidal pain. And this is something you need to talk to the patients, because they might have some ideation at some point, and you need to refer this patient to a psychiatrist. Now, this is a typical questions we used to do to the patients with complications, with severity. How intense does the patient feel? Mild, discomforting, and then whether or not this impact is so severe that it's affecting their quality of life. Not at all, a little bit. So these typical questions are extremely important to really have to the patients answered, just making sure that we understand how severely they might be in terms of personal image or in terms of depression. And this is something that is very important. Now, at some point, we need to also to do brain MRIs. And now that we have the chance to do a DTI for trigeminal nerve, you see this typical beautiful image. It's showing a typical brain that has been lesioned with the peripheral procedures. It's not showing up at all. So it means that it's been blocked. It has been deafferentated. There is no way you can see it here. And this is a proof of principle. You see when the trigeminal nerve is being severe by these procedures. Also, there are some post-op changes happening in the mesial portions of the temporal lobe. This might happen as maybe as a simple finding. We didn't want to cause this burning, but at some point, if you see it, you gotta be able to provide some medical benefit. Now, which are the competitive outcomes studies with all the series? I found this paper very interesting, and what this paper is saying actually was written last year. What this paper is saying about trigeminal neuralgia is that extremely difficult to compare apples with pears because a lot of the surgeons, a lot of the pain specialists, they compare using different techniques, and that's why they have basically concluded that at some point it's just impossible to draw any conclusions about it. And they describe all the pain scales, all the pain intensity instruments they've been used. And this might be one of the few papers actually comparing percutaneous balloon compression with retrogasseria and glycerol. And as you can see, most of the patients, they were using either one. And at some point, they came to the conclusion that a percutaneous balloon was much better in terms of patients' improvement along with complication. So this is a paper that I really enjoy every time that I read it because it was written by Dr. Campolat in Turkey. He did more than 1,600 patients with more than 2,000 procedures. He also was able to report 67 trigeminal patients with bilateral disease, which happens quite often. I have a couple of examples also. The average time for follow-up was 66 months, and basically the pain relief at 5 years was 57%. At the end, the recurrence rate was 70%. So we know that for sure these peripheral procedures are not 100% effective. However, if you compare all the techniques, and I'm sure there will be a couple of studies basically reporting this situation in terms of cost effectiveness and cost efficiency, trigeminal rhizotomy with radiofrequency might be much more beneficial than microvascular decompression. Just one of the randomized clinical trials utilizing different radiofrequency techniques. One is called continuous, which is basically the standard we use. And this paper is describing what is called pulse radiofrequency, which is basically pulses of a pretty intense high energy that is being delivered between 5 and 6 minutes. And then also there is another branch of the report that is taking combination of the two techniques. And at the end, this combination might be a little bit better than the previous ones. Again, which are the new methodologies that we can describe? Well, there is also foraminal valley cannulation using CT, and also, some new publications concerning the management of recurrence patients, as such as in this one. And basically, I would just comment on this that in general, whenever we see a patient with early recurrence, there is a chance to provide additional benefit with neuromodulation. Neuromodulation is a technique that we can use, going back again to the same approach, put in the needle, but instead of burning the trigeminal branch, we just apply basically a pretty high intense stimulation that is just lasting 4 minutes, and the patients can have between 80 and 90% of pain reduction. So again, and this might be one of the last that I can show to you. At the end, I guess we need to stick around with the basics of this. So if the patient is reporting the typical clinical syndrome, and if there are no any indication to consider maybe some brain tumors or some multiple sclerosis, then the patient has classical trigeminal neuralgia. The first step, we need to consider medical treatment. Either we do it as a neurosurgeon or the patient a specialist can do it. And these are typical drugs we can use. Carbamazepine is one of them. Oxcarbazepine might be the other one. And then the second line might be lamotrigine or baclofen. And these drugs actually work in some patients, and some of them they don't. And that's why we need to proceed with surgery in some of these patients, percutaneous approaches, gamma knife, microvascular decompression. Now, I'm gonna basically finish my presentation with something that I would just call marketing strategies. And I guess it is extremely important for a developing practice to really show to the patients how these procedures can be used to satisfy their needs, how these procedures can be done in order to offer them the chance for improvement. I'm pretty sure patients are desperate somewhere in the States, somewhere in any part of the world. And at some point, the patients don't even know there are procedures actually designed to help them to take care of the pain. This was a national TV spot. It was aired in Mexico 13 years ago. The first thing where I was surprised, right after the TV spot was aired, there were tons of patients coming to my clinic because they didn't know that there are actually procedures for trigeminal neuralgia. Some of them actually said, well, we didn't know you had procedures for this condition. I asked my odontologist, and he said there's no procedure for this, that I need to die or any condition with the pain. So this is something that I just wanted to mention, that at some point, all the information that we can provide to the patients, to the physicians, and we as a specialist, we can share common experiences. We can build all these centers to provide patients, with these procedures in order to improve them in their pain. So I'm just When I leave you with the video, I'm sorry for the language. It's going to be in Spanish, but I'm just showing you, what might be something interesting to consider for patients' awareness. So again, this was the opportunity that I was given to basically have this TV spot. It was just a couple of minutes long, and basically they were showing how we can treat a patient in live recording. So I was able to go to OR. There was a very nice lady with a lot of pain. So basically, this lady was coming to my clinic, and just a couple of days before the TV spot, I asked her if she might be an actress in the TV spot, and she actually consented. So we did the procedure in live, and then we were able to provide a total satisfaction with this procedure. And actually, the only thing that I wanted to show you with this video is how we can utilize this information basically to be able to really open up the opportunities for these patients to satisfy their necessities. We know that for some people, for some centers, these procedures might not be available. And I believe that we as neurosurgeons, we can take the lead. We can actually push the envelope a little bit more in this in showing that something can be done in order for them to get better. And I guess with this slide, I'm going to finish my presentation. And thanks for your attention. I'm open to any questions you might have.
Dr. Perez, I have a question for you.
Sure.
So, very nice, wonderful presentation. And trigeminal neuralgia, obviously, it's not everyone treats it. Not all neurosurgeons are trained to do this. So it's interesting that that you enjoy it and that you've done a lot of this. So looking at the different procedures, from stereotactic radiosurgery to the percutaneous procedures, rhizotomies, et cetera, angioplasties, et cetera. If you had a choice, you had a young patient that does not have a strong medical history, typical symptoms, they have, classic trigeminal neuralgia, they know when it started, et cetera. In your algorithm, I'm curious what you would say is the first procedure of choice that you would choose in that case.
Sure. Good question, Dr. Shah. This is I kind of like thinking somebody's going to ask this question because I know there's a tremendous debate about the microvascular decompression and the percutaneous approaches. And I'm going to bring the answer maybe echoing, what one of my colleagues actually was telling me. He told, if I happen to have trigeminal neuralgia, I'm going to go for a rhizotomy instead of the microvascular decompression. And this is a fellow that is 70 something years of age. And all I can tell, trigeminal neuralgia is an extremely difficult condition. Any patient with trigeminal neuralgia is going to go for procedures at some point because they get tired of using medications. If somebody has used carbamazepine, I haven't, but I've been told by patients that is the worst drug they can have, which is the best as a medical treatment. But if I happen to have a pretty young individual, let's say 20, 22 years of age, medical student, I would just advise to do a procedure, a percutaneous approach. Why is that? Because you can have a very limited lesioning. You're not going to burn the face. It's going to be a very limited approach. You can deafferentate, you can block the specific branch that this patient is having, and then utilizing all these techniques, they might be better in the next few weeks. Now, if somebody would say, well, microvascular decompression is a choice. Well, I've done microvascular decompression. It's not that simple. It's a posterior fossa operation. There is also some risks with the procedure. And even though the patients do fine, you need you are also a skilled surgeon. Just getting to the trigeminal nerve, you need to take the cerebellum, retract it, and just a simple retraction of the cerebellum. Even though, let's say, you were extremely careful not retracting the cerebellum, just retracting the cerebellum, I am a little bit concerned about some motor skills, kind of like in risk. And even though, for the best hands for a lot of publications, microvascular decompression seems to be like the perfect operation. My own experience and seeing the cases of somebody or some other surgeons, there are also complications that might arise with this procedure. So if this is a pretty young professional, looking for a, big shot at the end of the tunnel, or, some, great expectations, I would offer them the chance of this procedure, because at the end it's going to be fine for them. And at the end, I'm not going to risk anything more than a simple, approach, instead of risking sometimes, basically their performance as individuals. If this patient is musician, or maybe actors, some performers, they might have some, motor skills at risk. So I would just say that, for your question, and thank you for this question, I would just say there is always a place that we might consider these procedures upfront, instead of, microvascular decompression.
Interesting. That's very interesting, because this is an area of controversy, and for me, just looking at it, the one thing that I definitely think is a second or third choice is stereotactic radiosurgery. I don't believe it's a good choice. It's done just because we have to do it, because someone's got. But to do a percutaneous procedure like this, or an MBD, makes a lot of sense. But I think that as a group, it's something that is worth debating. I'm curious to see what Dr. Yin's thoughts would be. He actually just published on trigeminal neuralgia in a textbook with Slavin, Konstantin Slavin, over in Chicago. And so, there's definitely a lot of, debate over this issue of what's the best, upfront procedure to do. But again, to have everything in our repertoire, that as a practice, we can do any one of these procedures as indicated. I think that's wonderful.
Thank you.
Do we have any other questions? Okay, well, if there are no further questions, feel free to reach Dr. Perez offline if something comes up. Maybe you could find him on LinkedIn. And speaking of LinkedIn, please go to our pages, Insight on LinkedIn and on Facebook, and give us a follow. We post important information and updates for Grand Rounds and things like that there. So thank you guys all for being in attendance, and thank you, Dr. Perez, for that presentation.
Thank you. Thank you everyone for your attention.
Okay, take care.